Hi, everybody. It's Dr. Andrea Davis with Expect More today. And our guest today is a good friend of mine, longtime friend of mine, just off camera, talking about 17 years, I think we've known each other, give or take. And Cynthia Nossen, physician's assistant. Welcome. Thanks for coming.
Yeah, sure, no problem. So I'm Cindy Nossen. Cynthia, go by Cindy.
Cynthia,
Cynthia is
yes.
very formal. Yeah, just like Andrea said, we've known each other probably 17 years, which is when I started back at my orthopedic job that I'm still currently in with, at the time, reconstructive orthopedics. We've since merged with the big hospital system, Virtua. So we are now Virtua Reconstructive Orthopedics. I've been a PA for about 20 years. Actually, I have my 20-year PA school reunion coming up.
Wow. That's
The
crazy.
first 3 years of my career, excuse me, I spent in outpatient cardiology, actually. I ran a stress lab, did Coumadin clinics, those kinds of things. Wasn't really my jam. So had my own shoulder surgery, left while recovering from my shoulder surgery, and looked for other jobs and found this one. And I've been there ever since. So
I remember that too. I
mhm.
remember there was we used to do PA outings and I think it was game night or something. And I can't believe it's been that long. It's crazy. So what made you get out of cardio and go into ortho?
I was probably always destined to be an ortho. You know, what you can relate to. All through college, I was an exercise science and sports studies major, fully expecting to be a physical therapist. Actually, did some hours at Health South at the time, which I don't think exists. Yeah, when I was a student at Rutgers, I was doing some. I had a job as an aide, PT aide. Thought that's what I wanted to do. Decided that wasn't necessarily what I wanted to do, and started doing the research and found PA school because, of course, I also thought maybe I wanted to be a doctor. Then I thought better of it because as a woman, and we all know that's a hard thing to try and get through med school, get through residency, fellowship, have a family, those kinds of things. And like I said, found the PA profession. It seemed like a really good mix of everything. And that's what I started to do. So I've always had an interest in, athletics, sports medicine. I was a gymnast growing up, et cetera, et cetera. So I think ortho was always going to be my calling. The reason I did cardiology for the first 3 years, full disclosure, is my dad's best friend, who is a cardiologist in a huge group, basically handed me the position out of school.
Yeah, way to start.
So it wasn't so bad. But in addition, at the time, PAs were required to recertify in general medicine every 6 years. And honestly, I was terrified to go into a field that was a little bit more subspecialized. So I stuck with cardiology as a general medicine field on the off chance that it was going to be a problem for me to recertify in 6 years, whatever. But I really just, my heart wasn't in it. It was fine. The practice I was at was fine. A little tough. They were new to the PA world, weren't really getting wasn't getting a whole lot of support from the physicians and everything. And and again, it just wasn't my cup of tea. So I started looking at ortho jobs, had a couple interviews, hand surgery, things like that. And like I said, when I found this job at Reconstructive Orthopedics, it really sort of checked all the boxes, and clearly I've been there since. So
Yeah, not a bad move. I often wonder for myself, had I known about physician assistant work, if that would be a track that I would have taken, because I love being in the OR. As you know, I observed as much as we back in the day we could observe as often as possible, and I love being in there. And for you to be able to be in on the surgeries and then watch the recovery of the surgeries and follow patients through that journey is it's pretty awesome. Um, it's not, it seems like it's like we get a lot of kids that volunteer in the office that they say they want to do PT or PA, and you walk that walk. So is there anything that you could speak to maybe on that topic a little bit, on what you find to be the differentiators and what you found most attractive about the PA spot?
so what I found most attractive versus what I was finding as a PT aide and everything, I think, and you could correct me if I'm wrong, has actually changed a lot in the last 20 years. because at the time it was like, unless someone had a prescription for a very specific thing, PTs could not treat. Even despite all your education, knowledge, and everything, you examine a patient, you see them obviously more than we do. When I see a patient for 20 minutes in the office and I give them a prescription, I think I have a diagnosis, but of course you guys then evaluate them and you're like, no, this is a different body part that it's coming from. And it really bothered me that I couldn't treat a patient without a prescription specifically for something.
I get
And
that.
and it
Yeah.
bothered me enough that I was like, well, that's not what I want to do.
Yeah.
Now
Yeah,
I
you're
think that's
right.
obviously different. I think with a lot of you being PhDs and having the right, aren't there those?
Direct access. Yeah.
Yeah,
So
that
direct
that thing.
access where, yeah. So yeah, they can come in off the street, only 30 days in New Jersey. So
Right,
coming off the
right.
street, we can evaluate and treat you. But yeah, no, you're right. I did forget
So
about
that
that.
was a big factor for me. And so, like I said, I started doing a little bit more research into other things, and I almost stumbled upon it a little bit. And actually, I shadowed a PA that was at my original cardiology practice, who had been a PA for a long time, a bunch of days prior to applying to PA school, and I was like, yeah, this looks good.
So as a PA, because I have been around it a long time, but the ins and outs, I am not as well schooled. As a PA, where do your responsibilities start and stop? What can you do and what can't you do?
It's a little bit specific to the practice, the state, the subspecialty. In the state of New Jersey, which is mostly where I've worked, it was Pennsylvania for my cardiology job, but again, I don't even remember much. It's been so long. In the state of New Jersey, in theory, you have to be a phone call away from a supervising physician. So the difference between us and nurse practitioners, in practice, most of the time we are very similar. You will see us do very, very similar things. We can all prescribe medications. We can all fully treat, come up with a treatment plan, treat, prescribe those types of things. The difference is that nurse practitioners are independent practitioners and we as PAs are dependent practitioners, which just means that we have to see and have an overseeing physician. So nurse practitioners, you will see some of those urgent cares in the area that are popping up literally everywhere. They can be run completely solely by nurse practitioners who don't need to have some sort of an overseeing physician. PAs will never fully run those. If a PA is the one working there, there is definitely a physician presence somewhere on paper or by phone or in the office. And
Okay,
again, that's very
makes
state
sense.
specific. There's a lot of different rules from state to state. But that's sort of the difference and where we lie. But for the most part, we
You do
can
it all, right?
start to finish. Yeah. And
Yeah.
again, like you said, we, in my practice, are first assists in the OR. We do all the closing, there's parts of the surgeries that I've done, not without physician presence other than closing an incision. But again, in some surgical circles, the PAs
Hmm.
actually do a very large portion of surgery.
Large amount of that.
Um,
Hmm.
mhm.
Yeah, I mean
So
that's one of the coolest parts, I think, of the PA profession. And then your subspecialty, spine, which is probably one of the most complex orthopedic subspecialties out there. Really, I mean, is that pretty on point?
it can be. Can be. We see a lot of everything because of the fact that your spine is in the middle of the body. So, like
Hmm.
I said, when I was talking about treating the wrong body part, right? There are definitely times where I am sure someone gets sent in for a shoulder and you go, this is not their shoulder. This is their neck.
Times,
Cause I
sometimes.
get
Not
that
from
a
you though.
lot.
Not from you. No way. No way. I mean, you
So that can complicate things. Of course, you get neurologic problems. We do a lot of referrals back and forth to neurology. Spine surgery, I will admit, over the years, I see a little more cancer and tumor than I would have liked to have seen in my career because spine is a big area of metastatic disease. We happen to have a surgeon in our practice, Dr. Bob Greenleaf, who's wonderful with that stuff, that patient population. He's fabulous. I've learned a ton about that from him over the years. But yeah, I mean, it can be complex. It can be as simple as, go to PT, your back will feel better.
yeah. Yes, they are they are my fave sometimes. I think spine is scary for a lot of people, at least on the PT side. I've found over the years just teaching, and new grads usually shy away from it because of the perceived complexities. And I don't know. I find it at this stage of the game, I guess maybe it's you see it enough, you challenge yourself enough, it becomes if you have a systematic approach, it's not as complicated as you may think it is. Like, do you find it on your side the
I
same?
do. And actually, I agree with you in the PA world. All of our new people that come through who I'm training, again, you're right. Everybody sort of shies away from spine. Oh, spine. I don't want to do spine. I hate spine. But from my end, I joke because to me, it's very simple, right? You have very specific, almost like an algorithm for treatment of patients. I
Mm-hmm.
mean, they come in, they have all this pain, numbness, tingling, whatever the case may be. And if it's nothing that is neurologically detrimental, meaning any type of concern for surgical urgency or emergency,
Mm-hmm.
the run of the mill spine patient comes in with, I don't know, sciatica, right?
Mm-hmm.
And they're not getting weak. They're not having any true neurologic symptoms. You work on medications with anti-inflammatories, steroids. Physical therapy is always number one on my list. Most patients will get better with just that. And then when they don't, we talk about advanced imaging and injections like epidurals, facet blocks, all the different things that I send to the interventional pain doctors who are
Mm-hmm.
subspecialized in all of that. They're much better at all of those conversations than I am. And ultimately, when all else fails and people's lives are affected, you do surgery. We still, despite us being a surgical practice, we are all very much of the school of thought you keep surgery as a very last resort. Try all the conservative measures first. So that said, to me, it seems very, very cut and dry. But I get it. I get that people shy away. And some of it is the patient population too. There's a lot of stigma surrounding spine patients
There
because,
is.
yes,
Yeah.
you
Yeah.
do get chronic pain patients, people who had unsuccessful spine surgeries, who they're now dealing with things, people who are too complex to have any kind of surgery from a medical standpoint, and now they're dealing with chronic pain. And that is a tough thing to treat, particularly as a new grad or someone who doesn't necessarily have the strong personality to be able to, direct these patients, put their foot down, be real with them, explain. And sometimes it's just a matter of listening. Sometimes these people just want to tell you their problems.
No, I mean, you're so right. I love that you say that too, because like it's the confidence, I think, on the practitioner side to know what you don't know, but be able to relate to them in a way in which you're not like, well, we could do this. Like, well, okay, here's the deal. You've had this pain for a long time. You're unable, you're not surgically candidate at this time. These are the things that you can do to mitigate that. But I guess in spine, it's the same as like joint replacements or anything else, where quality of life is a big when it's not an emergent situation, right? Like I would imagine, not speaking for you by any means, but like emergent in the sense that there's, cord compression or some neurological deficit that is a sudden onset that quality of life comes into play a significant amount when deciding.
Definitely. That's usually what it is. I mean, again, like you said, without anything urgent or neurologic deficit, it's usually, I tell people this is symptom control. I discuss with patients in the office, this is not dangerous. This is not, scary. This is uncomfortable and very inconvenient. And if you can live with it, then this is what we do. And if you cannot, then this is what we do.
Mm-hmm.
And most of the time, patients too, just like providers shy away from spine. Patients, every one of them, I'm never having spine surgery. I am never going to have I was told never to have spine surgery. And I go, well, you have to consider the sources. Because often people hear the horror stories, right? It's like anything else. People hear the scary stuff, they hear the unsuccessful stories. And I always remind patients the people that talk about their failed spine surgery and their continued problems after surgery, they're the people that had a bad experience. The
Mm-hmm.
people who had a good experience went on to live their lives and don't talk about it.
You're so right.
So you have to remember who's telling you this.
No, I mean you're so right. And
Yeah.
people shy away from taught, like they try and live with it too. I feel like there's the opposite end, because we see a fair amount of that too, is where they try and live with it longer than they necessarily need to, and then potentially put themselves in a position where now it is too far, not too far gone to manage, but it's much worse than it could have been had it been intervened sooner. Like, do you see a fair amount of that
I
in?
do. We definitely see that. On the flip side of things, with you guys involved, I actually try to educate all of my patients that are sort of being treated for the first time,
Mhm.
or especially because a lot of them are being treated for the first time, but like they're like, oh, this has been going on for years and it comes and goes, but like this is the first time I couldn't get rid of it, or I just took some
Yes.
Advil and now it's not getting rid of it. And I actually have to start treatment. And again, the treatment plan usually consists of physical therapy. And my number one, like, quote unquote statement that I tell everyone is physical therapy is important to get you feeling better in the short term. Yes. But it is actually way more important in the long term to teach you the tools you need going forward to prevent these things from happening again and from getting worse. And it is something that you have to do for the rest of your life. Because
It's
I have the
true.
luxury of an x-ray machine in my room and I can show them their x-rays and say, this is what you got. It's not getting better.
Yeah. Yeah, I mean, spine is tough, and it is, I feel like it's something that can linger around, and if you don't have a systematic approach, or you don't have a ton of experience, and you're afraid of, potentially perceived to be making them worse, and you're not educating them, it can get out of hand pretty quickly. And I do think PT gets a bad rap a lot of times in the general public for, I went to PT and they made me worse. Well, did they? Or do you not have leg pain anymore, but your back
Yep.
feels worse, which is a good thing, actually.
It
Um,
is. It's a lot of education, a lot of education for patients.
a lot of challenging education at
Mm-hmm.
times too. I love models. Models help. Models help. So let's talk some surgical procedures, if you don't mind, because I haven't been in the OR in forever. So, give me some of your favorites to assist, or ones that that I'm sure they all have good outcomes, but the basic ones moving up more towards like a complex. Um,
So, I mean,
Lammies or
yeah,
discectomies.
your lammies, your discectomies, the basically decompressive types of surgeries that uh, routine young, healthy people, old people, basically you could have a laminectomy or a discectomy at any age. They're basically meant to free up nerves, mostly in the lumbar spine, no instrumentation. People generally do pretty well. Again, some of it is picking and choosing your candidates. A lot of it, and spine surgery is a funny thing because there's an old saying that says if you took 4 patients and 4 spine surgeons and put them all in a room and asked them what surgery they needed, you'd get 8 different answers. Um,
That is pretty funny.
because it's in the middle of your body. You can approach the spine, actually, believe it or not, people don't realize this, from the front, the side, and the back of your body.
Crazy.
So, that said, the laminectomies are generally, they're all posterior, and they're just decompressive surgeries with no hardware. If you're still staying with lumbar spines, we do fusions, which can be
Okay.
purely from the back, where we go in from the back. This is more likely people who don't just have leg symptoms, but also have back pain,
Okay.
because they have that mechanical back pain that is problematic from either bone-on-bone arthritis or spondylolisthesis, those slips in the spine that create abnormal motion. You need to take away that abnormal motion. Or people who have sports injuries from when they were in their teens and 20s they didn't know about until they started getting degenerative, those pars fractures that we all see so often and people don't know they have. Those are people we have to fuse because we need to stabilize that motion to take away that painful motion, that abnormal motion. And those, depending on where you're doing it, the patient body habitus, the surgeon training, it's all a little bit different. But you could do it from the back with screws and rods, bone graft. You could put an interbody spacer, a T-lift, which we call it, a transforaminal one. So that goes in from the back into the disc space and kind of opens up that disc space. You could do it from the side, which is a lateral interbody fusion, which works really nicely at L3-4. Because when you think about where your side is, you have your rib cage and you have your pelvis, and there's not a whole lot in between. So you can actually access like L2, 3, 3, 4, sometimes 4, 5 from the side. But again, those are a little bit more
Pretty cool.
specific for minimally invasive trained surgeons or people who trained with those specific procedures. They're some of my favorites to do. I actually really like those. And patients do really well.
I was gonna say,
And
what's the recovery time usually on the fusions these days?
the fusions, again, it depends on how many levels and how big and the
Sure.
patient's, you know,
Activity level,
activity level and what they want to be doing.
adherence.
But usually, I tell everyone first 2 weeks are the hardest. We're just having them walk. We don't start any formal therapy till about 6 weeks. But at that point, we're really starting to move and groove, strengthening, stretching, getting their motion back, getting all the core and back strength, that they've lost through the whole process back. 3 months, I tell them they have no restrictions. But I remind everyone that nerve recovery takes up to 18 months. Nerves do their own thing on their own time. And although I just told you 3 months, you have no restrictions, your body's going to tell you otherwise, right? Year to a year and a half of full recovery from any kind of spine surgery, but that doesn't mean you're not doing anything. It just means you had surgery.
Yeah. And you probably shouldn't be doing, whatever,
Yeah,
deep
exactly.
box jumps or something at 3 months
Yeah,
post.
there are certain things that you're going to be able to do and not be able to do, and everybody's different. But and then there's the cervical surgeries, which become a little bit of a different animal because the cervical surgeries are often done. Yes, they are done for arm pain and neck pain and stuff, but to be honest, more cervical surgery is done for what you mentioned before, cord compression. People with spinal cord compression have a lot of debilitating symptoms that they chalk up to being old or clumsy or whatever, but things like dropping things unexpectedly, trouble with fine motor skills, loss of balance, handwriting getting worse, buttoning buttons getting harder. People don't realize that can actually be coming from compression on your spinal cord. And those become a little bit more urgent surgeries to decompress the cervical spine.
Yeah, I mean, that is a really great point. And I know we try to go through screenings too, and that can be challenging. And it's usually one of the spine comes up a lot, I think, in our world anyway, PT world, for direct access as far as, are you helping? Should you be? You don't have imaging. What does that look like? But I think for us, if you know what the red flags are, like all the things you just listed, it helps mitigate some of that as well. And if they're not progressing or improving, when in doubt, ship it out. I mean, that's really the mentality that we should be in with direct access and spine, because people usually get a little skittish about seeing a PT before they come in and see you guys or go to urgent care to have imaging done. And the reality of the situation is, if there's not trauma or something like that, potentially we can mitigate it, but imaging's not going to fix the treatment really or dictate the treatment, but it certainly can explain the symptoms for the most part. Right.
Yeah.
Can you speak a little bit about the MRIs around that? Because I know a lot of times, right? I know. So we get it a lot. If I get low back pain, they're like, I want an MRI. And I'm like, it's not going to change what we do. You're presenting as such. I want an MRI. And I'm sure you get that a significant amount of time. Yeah. Right. Why do I have to go to PT?
Patient.
Yeah. Why do I have to go to PT? Yeah. Just get me an MRI.
Right.
So
and
please.
If I'm being honest, a lot of times the only thing that gets the patients to go is I say, look, your insurance isn't going to approve it. So you got to go and do it.
You
and
got to go to PT.
Like, I don't know what to tell you, but that doesn't give you guys a bad name, or a good name, but it's true, unfortunately.
Fine. Yeah.
But it's true. And I have said to patients who are like, no, I need an MRI. And I'll say to them, look, if you came in today with an MRI that showed you had a big disc herniation causing your symptoms, I would still send you to PT. Right. I would still give you the medications. I said, because unless you're ready to rush off to surgery, and then people go, oh no, I don't want surgery. I'm like, well, right. That's your option. Or I say, oh, or you could have an epidural injection. And they go, needle in my back? No, I'm not going to do that. I go, well, then I don't know what you want the MRI for.
Yeah. I mean, I guess it's maybe peace of mind. Maybe,
it is.
I guess
people want to know what their diagnosis is. And I get that. I do, but, and again, it comes purely down to education. It doesn't change what we do. You can have a diagnosis, and I'll sometimes say to people, okay, you have a disc herniation. There's your diagnosis. Like, how do you feel now?
What else can I do? It's the same thing, right? Yeah. I just, No, it's the spine world has definitely been less scary over the last 15 years. It was definitely something I distinctly remember too when I had to like just make a decision because I would shy away from them and I'd be afraid I'm going to hurt them. And then I just had to decide I wasn't very good at it. And then I got really good at it for a while. And now it's just like, okay, it's fine. You know, what is everybody so afraid of at this point? So, favorite things about your job?
I love my team.
Yeah, that's
I
good.
love
You
having,
have a great team.
yeah, we have fun. We have work days and social days, and that's still fun. Harder now that
It's
we're bigger,
awesome.
but,
Yeah.
so I love my team. I love the autonomy of being able to do what I do, assist in the OR, fully treat a patient from start to finish. But if I'm not sure, I have the physician backup. I love having that person to rely on that ultimately is going to be the final decision. If there's something that's new to me that I'm uncomfortable with, that, you know, that I am just not that well versed on, you know, I look at imaging and I go, what the heck is that? I have someone I can ask. And I love that that's something I can always do. Oh
So even 20 years in, you're still learning.
my God, every day,
Yeah.
every day.
That's I love it.
I
Yeah,
saw
well,
something in the OR the other day that I had never seen before.
stop it. And you've seen a lot. I know you've
Seen
seen a
a
lot.
lot. I've seen a
Yeah,
lot. And I was
you
like, I have never seen that before. So
wow.
people's anatomy is always different. Everybody's, you know, you never know. Once you cut that person open, you don't know what you're going to get.
Yeah, I would imagine
So,
that to be true.
yeah.
It's like a whole new world in there.
Mm-hmm. Mm-hmm.
Any things care to comment generally speaking about healthcare in its current state? If not, I understand. However, I have my
Uh,
own comments.
well, healthcare is something we will always need.
Yes. Yes.
So in theory, there is job security in healthcare. Uh, there are a lot more barriers, obviously, than there used to be to
Yeah.
treatment of actual patients, in some senses. But again, in your world, like I said before, you know, you used to not be able to do things, and now you can actually do things you couldn't do
Yeah.
before.
Very different.
But for the most part, you know, back to the MRI conversation, like, would I love to just be able to order an MRI on every patient? I would. The nature of the healthcare system is that the insurance companies rule. And, you know, when in doubt, blame the insurance company, and the patients tend to get less mad at you. And I tell them, call your insurance company. You know,
Same.
I think it's going to be an ever changing world. At the same time, going to socialized medicine like they do in other countries is not better. You know, you hear people who come from other countries who are like, there's no way you can't get any kind of care. So, you know, access is definitely better in this system, but maybe not cost effective
Yeah.
and anything else. So I do think it's tough. You know, as providers, we have more red tape to cut through, and less of us, more patient population. You know, burnout's a real thing. Am I telling my high school child to reconsider the fact that he wants to go to med school? Uh,
Possibly, maybe.
no.
No, we wouldn't do that. My
He
daughter
wants
wants
to
to
be
be a
an orthopedic
PT.
surgeon. I'm like, oh
Oh,
God.
it's amazing. Yeah,
He'd be
same
good
boat.
at it. I'm not gonna lie. He's only 15, but I think he'd be a good one.
It's awesome.
But you know, I think it's gonna change. I gotta believe it's like college tuition. I gotta believe there's got to be a swing the other direction at some point.
I hope so.
I don't
And
know.
you and I 20 years, right? So when you started
Mm-hmm.
in the field, I think, and correct me if I'm wrong, but I know when I started in the field, it was pen and paper
Pen and paper.
notes,
Yep.
and now everything's digitized, and was supposed to be better, but continues to be presenting with its own challenges. And I would like to believe it is going to get better, and I would like to hope that I'll be able to participate in that when it does start to shift. But I can tell you hands down, from me to you, from a local perspective, still one of the best PAs in the business. You're kind and generous, and with your time, with your patients, and super intelligent. And the part that I think I miss the most from the older days, so to speak, is the fact that you had more time to spend with people. And I think, and I mean this very much. There's like a small group of you. I don't know all the PAs in your practice. I still only know the small core group that I grew up with, so to speak, in the professional world, that still kind of clings on to taking care of the patient, taking the time. They deserve time, attention, and to be heard. like you said. And for that, I thank you very much, because
Well, thank you. I appreciate that.
it keeps me grounded, and I feel the same way, but it is hard at times. So it is nice to even catch up like this and, hear you speak like that. It's awesome.
Well, thanks.
Yeah. Um, any closing remarks, my friend Cindy?
No, not really.
Yeah.
Just do PT if you have a spine problem.
That a girl. Yes, I'll take it. I'll take it. Any advice to graduating seniors considering healthcare in college or PA school? Any advice to them? Good tracks, volunteer, observe, anything?
Yeah, basically get your hand in there wherever you can. Again, 30 years ago, 25 years ago, that wasn't a thing. And I almost wish it had been. I think shadowing, getting into offices, and it's harder now, particularly in a post-COVID world. But I think get involved in any kind of healthcare, in all different levels of healthcare, because maybe it's not what you think it is, and maybe you change your mind, like me.
Yeah, yeah, really.
I was PTA, thought that's what I was doing, and here I am. So
Yeah,
you never know. You never know.
a spinal PA, PA
Which,
of
by the way,
many.
if you had told me I was going to do spine, I'd have laughed at you, because in PA school, the one class I almost failed was neuro, just for the record.
Stop. Oh my God. Yeah. Well, I tried really hard not to finish PT school in light of having
See?
too much fun. So I know. And now I'm like kind of a nerd. So it is what it is. We end up where we're supposed to, I think. But
I guess so.
thanks so much for coming on and talking to us about spine. And super grateful for your time, attention, and keep doing you for sure. And I appreciate the work. So thank you.
Yeah, great. No problem. Thanks for having me.
All right. If anybody wants to learn more about Cindy, is there any websites or contact information you'd like to share?
Hmm.
I
Good
think
question.
it's virtua.org, if I'm not
Yeah.
mistaken.
Yeah.
Uh,
Virtua.org is the website. There's a lot of us, but I'm on the website there like everybody else. And, you can certainly contact our office for appointments, and they'll get you set up and squared away.
and they are all over the place. Do you work in a particular site, Cindy, or are you all
I'm a little bit all over the
around?
place too. From an office standpoint, I'm usually in our Morristown office, and I work in Sewell one day a week right now.
Okay. Nice.
But we have offices at the moment, active offices spanning from Bordentown, New Jersey, all the way down to Vineland, with now a Summers Point office at the
Amazing.
shore, and everywhere in between. So
You gotta get in on that shore office and
yeah,
hang out
I'm
down
not
the
a beach
beach.
person.
Oh my
I
God, I
know,
didn't know that.
a beach person. I'm a mountain
What are you?
person. You know.
Okay. All right. That's fair. We can work with that. Not many mountains in New Jersey, but we can work with
No.
that. Well, that's it for us today, and expect more. This is Dr. Andrea, and I'll see you next time. Thanks.